I'm sure Dr. Gaurav needs no introduction. He's the director of the Drishti Eye Hospital, Dehradun. He's the chairman ARC of IRSI and an extremely popular dynamic cataract and refractive surgeon. And I'm truly lucky to have him with me in my course. And he's going to be talking. 8 minutes. 8 minutes. And he would be dealing on update on epithelial mapping and their relevance in refractive surgery standpoint. On to you.
Thanks. Thank you, Dr. Chitra, and very good afternoon, everyone. I think it's a privilege to be in Dr. Chitra's course for the last couple of years. It's been very interesting. So, ma'am has asked me to speak on epithelial thickness mapping, which has been very close to my heart all these years. We started doing this about 6-7 years back, and ever since it's become almost as invaluable as a topographer or a pentacam for our refractive surgery workups and follow-ups both. So the epithelium thickness mapping came about when OCTs started getting better and better, and once the OCTs were able to pick up the epithelium, then it became much easier, because then they had to just do the checking whether it was a predictable and reliable thing, and then they found that it was pretty predictable. So the one which I've been using is the Avanti RT View, but the others like the MS39, which is newer, and even the Cirrus now, they have excellent epithelium thickness mapping abilities. And so these studies were done by Dan Reinstein, and they found that the range of error for the automated epithelium thickness mapping was very, very small and comparable to what was in the gold standard of the manual measurements of the epithelium thickness based on the OCT. And this was the repeatability which was reported by David Huang et al. And also patients with keratoconus, you could see that the thing was equally predictable when picking up keratoconus, where the epithelium where the epithelium changes, which I'll show you how it changes. So this is the normal eye, and average corneal thickness is about 50 microns, but it can give you a surprise. Sometimes I've actually seen corneas with 470 or 480 pachymetry, and then corneal epithelium thickness of 55. And on the other hand, so you cannot generalize. And when we do feed, especially for those of us who are doing trans PRK, if we feed epithelium thickness without checking it on OCT, we can actually go wrong by quite a big way. And there are corneas which are thick, and maybe 600, and you may have a epithelium thickness of just about 49 or 50 microns as well. And these may be all normal. So post laser vision correction, epithelium thickness changes have to be documented, and they actually tell us a lot about how the refractive surgery went off. And you can have post LASIK, if you are doing a myopic LASIK, you will obviously see a central epithelial hyperplasia because of the remodeling. And with PRKs as well, you will see the similar change, but you may in the early days of PRK see different epithelium healing responses, where the epithelium may be very thin to begin with and gradually builds up. And all this helps in understanding how the healing response to various kinds of refractive surgery are. Now the other area where the epithelium mapping becomes really useful is in suspect corneas, where you are trying to see if there is a possibility of a keratoconus. So obviously in frank keratoconus over the area of the apex, which means that the thinnest pachy, you will have thinning of the epithelium as well. And you will have compensatory hypertrophy in the areas around it, or exactly opposite to that, and that will tell you about keratoconus. And let's see that this is a more advanced case of keratoconus, where this is the thinnest pachymetry of the cornea. And you'll see that this is also the area where, because of the cone, the epithelium compensatorily gets thinner as well, because of the the tip of the cone, and then you have compensatory hypertrophy. So this is a very typical pattern of what you will see in the epithelium thickness maps. But these are those established maps, and in very subtle maps you'll actually see a very subtle change, and you may actually not pick up any kind of deviation on the pentacam maps or even on the topography maps, but you may be able to pick up subtle changes like this with a little bit of epithelial thinning on the cone and compensatory hypertrophy around, so that the surface remains smooth for the placid or topographer, but the OCT picks up these early changes, and that's where the value of the OCT lies. Now this is another patient with a central ortho K induced epithelial thinning, and post refractive surgery, as I said, post hyperopic LASIK, the change will be totally different. And in fact, sometimes if you are suspicious of somebody having undergone a refractive surgery, a good idea, especially if somebody has refractive surgery for small errors and is not being picked up very clearly on topography or on pentacam, the epithelium maps will give away, and you will see the difference in the epithelium thickness mapping. So if you're not sure whether somebody has given you a correct history of refractive surgery or not, this can again be a very useful tool in picking up as well. So in hyperopia, you'll actually see that there is, because all the laser ablation happens in the paracentral area, you will have compensatory thinning in the center, and you'll have hypertrophy, epithelial hyperplasia in the area of the gut ring, which is induced by the hyperopic corrections. So it's exactly opposite of what you would see with myopic LASIK. And this is obviously myopic PRK, where you'll again see hyperplasia in the central zone of the optical zone, and some compensatory hypoplasia all around. So this is reverse of what you will see with hypermetropic ablations. So these are of course the stromal maps, which you can also derive once you've removed the epithelium thickness from the full pachymetry maps. The newer versions of the software allow you to actually get a stromal map as well, which again is very useful to differentiate from, once you've subtracted the epithelium changes, you can actually see whether the stromal or the Bowman's topography is actually good or not, because that can tell you a different story. And many corneas which appear to be suspicious otherwise because of epithelial changes may actually not be suspicious, and you may be able to pick up those and not unnecessarily deny a refractive surgery to a patient who only has epithelial changes rather than actual suspicious cornea. So this is again a patient where you will differentiate corneal warpage, and these are not unusual to see even when you tell patients to come post contact lens, stop using contact lens for a week or 10 days. You may still pick up warpage, and you sometimes have to put these patients on almost a month of contact lenses before the cornea actually comes to their virgin state. And as compared to this, the keratoconic corneas will show epithelial thinning in the central area and near the apex, whereas here you'll see epithelial hyperplasia. So the two have to be differentiated because on topography they may look similar. So dry eye has not really shown much about epithelial mapping. Can go either way. You can have hyperplasias and you can have epithelial thinning. So there's not much that I will be able to add here, but the applications of epithelial thickness mapping are tremendous, and especially our post CXL follow-ups, post refractive surgery follow-ups. Besides decision making for refractive surgery, it can be very useful. So this was a patient where you can see that the left eye there was a skew with the steepening, and we picked up on the Bellin maps as well. There was anterior changes on the cornea on the front anterior maps, and this was on the left eye, which was obviously showing up more changes on the front surface than on the back. And when we went ahead and did the epithelium maps, you can see that the right eye and the left eye shows a clear situation where there is a possible ectasia because of the thinning over the area of the apex. And here you can see the compensatory hypertrophy instead. You're not seeing much thinning except maybe a small island here. So both these eyes are definitely not healthy corneas. They are both suspect corneas, and this really helps you in making sure that doubly sure if you are picking up something, and if you're not picking up anything, then kind of gives you some room for doing some other surgery. So refractive surprises, I think I've used epithelium mapping has been really useful tool, because I was discussing with Dr. Chitra, I wanted to show maps here of some of our SMILE patients. Now in SMILE, we've seen that the epithelium remodeling is very different. I couldn't download them because there's no internet here, and I was trying to get mails from my clinic, but couldn't get them. Here I would like to point out that 2 weeks back, we had a SMILE patient who's almost 6 weeks post-op, continues to show a hyperopic surprise of about plus 0.5 to 1 diopter, and patient is very concerned that he's not able to see well and not read well at all. And we, as usual, would do our epithelium maps, and to our surprise, we found that the typical remodeling, which is expected at 6 weeks, with some amount of epithelial hyperplasia already happening in the central zone of the flattening, has not even started yet. So the epithelium maps were identical to the pre-op maps, which means that 50 microns pre-op and even 50 microns now. Typically at this point, if I had done a 5 or 6 diopter ablation for a SMILE, I would have seen maps showing about 55 to 56 microns or even more of hyperplasia, and that is the thing which regresses the hyperopic shift which is seen immediately post-op. So this can help us monitor these patients. I'll finish in 30 seconds. So again, for surface ablations, some of these surface ablations, when they're healing, the healing can be very variable. So some people will have epithelium remodeling happening very fast, and others will have a slow one. And some of them, when the epithelium is closed, you remove the contact lens, they still come in at about 1 month saying that they are not clear. And if you do their epithelium maps, you'll find that there's that fracture line where the epithelium has healed, and where you have a central linear line of fusion, and they will have high astigmatism, and some of them will not be good. So you just have to reassure them, put them on more lubricants, and allow them to settle down, and they will all settle down. So it's very easy to explain patients and yourself if you're getting some kind of unusual post-refractive surgery situations. And also lastly, enhancement planning. If you have enhancement like this, you know that you have central steepening of epithelial hyperplasia. You cannot do trans PRK, so you have to keep that in mind, and ensure that you do a brush assisted removal or alcohol assisted removal. Otherwise, you'll end up with a bigger surprise as well. So I think I was able to convey the message, and I'll stop here for the next speaker. Thank you.
That was a very useful talk, and that definitely told us about the roles of epithelial mapping. I have two questions for you. Do you use epithelial thickness map as a screening tool regularly before LASIK, more so for cases of borderline topographic changes?
I use it for every patient for refractive
Yes.
surgery planning.
Yeah.
Absolutely.
And what would stop you from doing LASIK for those patients?
So sometimes you'll pick up corneas which are suspect on maybe a pentacam, and then you'll want to double check them on the epithelium maps. Many times the epithelium map will show that they are pristine, and some of these bad maps are actually showing up false alarms. So then you can kind of look them up further and see that if all the other modalities are showing that there's nothing wrong and just the bad maps are looking suspicious, you may still go ahead with the refractive surgery. On the other hand, you may have a cornea which shows up kind of a asymmetric bow tie or a small steeper inferior steepening, and you may be wondering whether this is, so the epithelium maps help you decide whether this way or that. So it's like a second check on all these patients, and whenever you have suspicion. Of course there are pentacams which are absolutely clear, and you may not have much value from the epithelium maps there actually.
Now, in case of a post-myopic ablation, I'll ask you, Shrey, needing enhancement with epithelial hyperplasia as seen on AIOC2022, would you like to follow up this patient with serial maps to look for stability, I'm asking you, or would you do enhancement, or would you want to do a PTK and then plan a refractive correction later?
I think a couple of points. One, wonderful presentation, sir, great maps. And quickly about the enhancement part, I would definitely say where compensatory epithelial hyperplasia has a major role in small regressions, you would definitely have to wait to ensure that it is stable. But more importantly, when you treat them, how do you go about treating them is actually a major challenge, especially in late regressions, not in early regressions, but late regressions. There, the epithelium has been stable for some time, and if we ablate transepithelial PTK, and we end up, let's say, the scan which you showed, very classical 72, 74 microns, there is about couple of diopters of myopia induced by the epithelium itself. So if we just remove the epithelium, when it grows back, how much will it grow back to is an unpredictable factor. So what I would do would be a two-stage thing. I would remove the epithelium first, allow it to stabilize over the next 4 to 6 months, and if there is a residual error, then do a PRK for that residual error. But very often it goes away with just that, and I've had patients with just pure astigmatism also where it goes away with that, sir.
I have a question to both of you. How many, you don't have the machine, but for you, if you have epithelial thickness mapping and we say that's regression, etc., etc., has anybody correlated this with ocular hysteresis?
So it doesn't correlate at all, sir. I mean, forget regression. Even patients with ectasia, it does not correlate extremely well, sir. Very advanced ectasia, yes, easily. But early ectasias, it doesn't correlate at all, sir. In fact, even on the, I have a slightly contrarian view on epithelial thickness as a screening tool also. While what sir showed were classical maps where you had the typical thinning at the apex and around the base of the cone where there is thickening, there has to be a sufficient change in curvature for such epithelial changes to manifest, sir. When we are talking about very, very subtle changes and minor ISA symmetry, where the curvatural change is not very significant, the actual change in the epithelial thickness map will be in the range of 1 to 2 microns. And there are a lot of things which affect epithelial thickness, not just this thing. If there's a contact lens wearer, there's some dry eye issues, so many other things which change epithelium, that I find that while it is corroboratory, it is difficult to use it as a standalone